My name is Dr. Jonathan Kuttner. I'm a musculoskeletal and pain specialist. Today we're going to look at the function and the anatomy of the shoulder. It's a fascinating joint. It's the most mobile joint in the animal kingdom. And the thing about mobility is that if you want mobility, what you lose is stability. And always, all joints have this dynamic tension between them. So if you take a very stable joint like your hip, the head sits in a nice big cup and it has quite a lot of stability and limited mobility, whereas the shoulder, incredibly mobile, not stable at all. The thing that you also get with mobility is the more unstable a joint is, the more likely it is to have injury. And the shoulder is proof of this. It is a very, very common joint to injure. So, it is complex, and I know everybody who deals with the shoulder finds its complexity a little bit boggling. And so what I'll try and do is give you my take on how the shoulder works and my way of making sense of its many layered complexities, because the shoulder is not this. The shoulder is a large joint which does many things. So here is a shoulder. And what you have is you have a base, which is the scapula, and then you have a joint, which is the glenohumeral joint, and then you have the arm, which is the extension of the shoulder. The shoulder is attached to your axial skeleton with one bony attachment, and it's this tiny little bone. So the collarbone has a joint, the sternoclavicular joint, and the acromioclavicular joint, which is the only bony connection of this whole amazing structure to your body. So if we start with the base, and the base, here's the scapula. The scapula sits like this in your body. It runs over the back of the thoracic of the thoracic ribs, and it sits on a base of what's called loose areolar tissue. It glides backwards and forwards, and the reason it glides is because it allows movement of the glenohumeral joint, and as you get movement of the glenohumeral joint, you get that huge range of movement. So again, this base actually has to support this incredibly long lever. The base itself, apart from that little bony connection, the rest of the base is muscles which fix the scapula onto the thoracic rib cage. Now, this is fascinating because there are huge forces there, and the shoulder muscles, the stabilizers of the scapula, have to be incredibly strong, and they have to be terribly appropriate. They have to contract when they need to release when they need to. So that's your initial problem. Now, they have, and I'll just take a step back, broad concept. In the shoulder there are two types of muscles. There are stabilizers and there are movers or power muscles. So the stabilizers for the scapula need to be incredibly strong, and they need to fire when they need to fire. Now, there is an extra problem with the muscles, the stabilizers of the scapula. If you take, say, the ones that run down the medial scapular border, the rhomboid muscles, these run from the scapula and attach to the ribs and the thoracic spine. Now that's stable. So this is great because the muscles, as the shoulder blades glides back and forwards, these muscles have a nice firm attachment. Great. Problem. There are two sets of very, very important muscles. The first is the trapezius, which runs along the edge of the spine of the scapula. And the second is the levator scapula, coming up from the superomedial border of the scapula. And both these muscles actually attach to your neck. And the problem with this is that the scapula is already mobile, but so is your neck. So if you look, say, at the trapezius muscle, if your neck firms up, and now you're asking a whole lot of other muscles to go into spasm, and the trapezius contracts, it will pull the scapula up, which you need to do that movement. However, if the scapula firms up, it will pull the neck down. So once you've got this incredibly dynamic, fluid situation of the two fixation points for these muscles have the ability to move, and each one has to behave completely appropriately if you're going to do your complex movement. You can see now there are layers and layers of fantastic mobility, but difficulty. Right, now we come to the next absolutely fascinating part of this fascinating joint, and that is the glenohumeral joint, which is actually the shoulder joint itself. Okay, so the glenohumeral joint, again, concept, we want mobility. So to get mobility, what you need is a very small little cup. And here it is, the tiny little glenoid fossa. It is small and it is shallow. Coming into the small and shallow cup is a great, huge sphere, which is the head of the humerus. It has to be much bigger than the small cup so that it can be very mobile. So what your body does, whoever designed us, is that there are two ways to get some kind of stability here. The first is around the rim of the glenoid cup there is something called the labrum. And the labrum is a very thick and strong fibrocartilage rim that comes around the end, and that rim adds a little bit of firmness, allowing a certain amount of movement. You get a similar labrum in the hip, but this is a much more significant, large labrum. But the second, which is really the fascinating thing about the shoulder, is that you have a series of 4 muscles which all arise from the scapula itself, and these muscles form a dynamic stabilizer for the head of the humerus. So there's nothing like this in the body, and in fact when you look at the animal kingdom, you know, human beings and the great apes are the ones with this huge amount of mobility, where this dynamic stabilizer of the head of the humerus is best designed. So, as I said, large head, small cup. If I am moving my joint, if my shoulder joint is moving, the center of rotation of the head of the humerus cannot move more than a few millimeters away from the center of the cup. Otherwise the joint will dislocate. So the shoulder joint actually has amazing rotation. If you take just throwing, as you throw, there's a spinning of the head of the humerus. If you take the extreme of throwing, like a pitcher in baseball, what they do is that the arm comes back and then the whole body, I can't do it, but their whole body flies forward, leaving the arm behind, which then whips through, and it's an incredible dynamic movement. In that kind of movement, the rotation of the head of the humerus is thousands of degrees per second. So they can do this in a totally predictable way, not only to throw incredibly fast, but to throw a curveball or all these weird and wonderful things that baseball pitchers can do. And they do this whilst the head of the humerus doesn't move more than a few millimeters from the center of the cup of the glenoid fossa. Okay, so the way that the rotator cuff works to allow this amazing function is, firstly, there are 4 muscles, and the base, which is the scapula, is the key. The scapula has a spine that runs along it. This is along the back of the scapula, and you can see that the spine comes up at an angle and it creates a groove here. So above the spine is a muscle. Above the spine is a muscle called the supraspinatus, which means above the spine. This is an incredibly important muscle. It arises from that cup and it runs forward through this little gap, forms a thick tendon which runs across and attaches to the greater tuberosity of the humerus. Running like that, if you can see my finger running through. Okay. The next muscle is the infraspinatus, which arises covering most of the portion underneath the scapula, underneath the spine, and it runs across and it wraps around the back. And about here is where it becomes a tendon, wraps around the back. The teres comes lower, just from this area here, and does the same thing, but coming from a slightly different angle. And finally, in front of the scapula is the subscapularis, and it's the biggest of the rotator cuff muscles, and it runs across, running around the front. And all these join together to form, the tendons join together to form the rotator cuff, a dynamic stabilizer of the head of the humerus. Now, if we take having these concepts in your head, if you go back now, and there is a question that popped up in my head a while ago, which I've asked a number of doctors and hardly any of them get it right, and that is this. What function does the shoulder, what is the function of the shoulder that keeps you alive? And I can't ask you because but I want you to think about that for a second. What is the function of the shoulder that keeps you alive? And if you didn't have this function, you'd actually die. And the answer is, it puts food in your mouth. So this movement, which is the most fundamental movement of your shoulder, keeps you alive, and it is how the shoulder is designed to move. So if we come back again, the scapula sits like this, and it sits on your body, so I'm attaching it in the way that it would sit in my body. The glenoid fossa actually points, it's angled slightly like this, so it's forward and to the side. It's not straight out. And this allows me, this plane of movement you see is coming across my body and putting food in my mouth. So everything about the shoulder is designed to make this particular movement work. There's nothing gets in the way. So as you do that movement, everything glides. And so when you look at shoulder problems, this is the movement that is least troublesome, that causes the least problems. So that's this plane, and therefore, if you think, okay, what movement is furthest from that plane, it is that. So this is happy, that movement, which is abduction, that movement carries with it an enormous number of problems, or potential problems. So let's come back to the rotator cuff itself. The important muscle in the rotator cuff for abduction is the supraspinatus. It is the absolute key muscle for abduction. And the way it works is this, that the Supraspinatus runs from above the spine across here, attaches to the greater tubercle, and as it contracts, it pulls the head in and down. That's what it does, in and down. So it sucks the head into the glenoid cup, stabilizes it, and pulls it down. That's great. That's a good beginning. Okay, now remembering that the muscles of the rotator cuff are dynamic stabilizers, there's a second group of muscles which are the power muscles. These are the movers of the arm or the shoulder joint. And really the most important of these is the deltoid muscle. So the deltoid muscle, which is the muscle that gives bulk to your shoulder, it arises from the edge of the acromion and from the front, the side and the back, and it runs around in a large, powerful muscle and attaches lower down the humerus. So, if you want to lift your arm up, the muscle that's going to do it, the power muscle, is your deltoid. So, there are the two muscles. There is the supraspinatus and the deltoid, both of which are absolutely necessary for you to abduct your arm. The deltoid attaches here and runs down there. So when it contracts, it will pull the arm up like this. And it will come around and it will pull the arm up. First movement. Now, the secret to lifting your arm up so that you do not have pain, which is the difficult movement for the shoulder, is that the sequence of firing of these two muscles has to be absolutely precise. As you decide, I'm going to lift my arm up, the first thing that fires is the supraspinatus. It has to be. So the supraspinatus fires, it pulls, it sucks the head into the glenoid fossa, pulls the head down. Now, in this situation, it's firm, it's stable, it's low. Now when the deltoid pulls, everything just slides in. And the tubercle slides in underneath the acromion. There's heaps of space. Under those circumstances, you have free, comfortable, painless movement. If, however, the supraspinatus is slow or doesn't fire properly, or if the supraspinatus is damaged, then the first movement that occurs is the deltoid contracts, it pulls the arm up, and now as it starts to pull it in, the head of the humerus digs in to the acromion. And the medical name of that is impingement. So the commonest cause of shoulder pain is impingement, which occurs with damage or incorrect firing of the supraspinatus muscle. If the humerus gets pulled up and this digs in there, what will happen is that there are two structures that become damaged. The first structure is the supraspinatus itself, because the tendon runs over the top of the humerus. So if the humerus gets pulled up and digs in, it will damage the tendon each time you have that, each time it impinges. The second is that there is a bursa, which is a sac, which runs over the head of the humerus, and the bursa is there to allow smooth gliding. But if this comes up and digs in, the bursa becomes damaged. So you end up with subacromial bursitis and damage to the tendon. The thing that happens now is circular, because it hurts and the tendon has become damaged and the bursa starts getting inflamed, and therefore the tendon is inhibited, the muscle is inhibited from working because it's damaged, and the whole thing is grumpy. And so every time you go to make the movement, it digs in more. The tendon becomes more damaged, the bursa becomes more inflamed, and this is essentially the primary problem that occurs with shoulder pain. When you do impinge under here, the place that you feel your pain is not in under here, but the place you feel it, the place your brain localizes it to, is the outer upper arm. So people, they'll lift their arm up, and as they do that, they'll go, ah, and they'll grab this part here. And this is what's called somatic referral. And the reason for that is that the nerves that supply this area carry on down the arm, and the information that reaches your brain is an imprecise amalgam of all the information coming from the nerve. So it hurts here, but the message arriving is not precise, and your brain takes a punt and localizes it to this area. So that is the single most important cause. 90% of the time that you have a rotator cuff problem, it will be the supraspinatus tendon, because it's a weird design fault. And once you have that, you will inevitably end up with impingement in this abduction movement, which is the most difficult movement for the shoulder.